My name's Dr. Judy Mangione. I'm the Associate Director of the Non-Invasive Cardiac Laboratory at Brigham and Women's Hospital and Assistant Professor of Medicine at Harvard Medical School. It's my pleasure to be speaking to you today about echocardiography in preparation for the American Board of Internal Medicine initial certification and recertification exam in cardiology. I have no conflicts of interest to disclose in relation to this topic. Echocardiography remains the most common imaging modality in cardiovascular medicine. Now, the ABIM recognizes that echocardiography is at the heart of clinical cardiology. However, if you review the blueprint of the cardiovascular exam, you won't see a separate medical content category for echocardiography. However, you can expect each category listed will have questions that relate to echocardiography data in images. So this slide just covers the 2018 ABIM Cardiovascular Medicine Board exam blueprint. And I highly encourage you to go to the ABIM website to get the latest news with regards to this blueprint. But as you can see, arrhythmias, coronary disease, heart failure and cardiomyopathy, valvular disease, pericardial disease, congenital heart disease, vascular diseases, systemic hypertension and hypotension, pulmonary circulation disorders, and systemic disorders affecting the circulatory system comprise the ABIM exam. And there are many opportunities within each medical content category to provide questions that relate to echocardiography data as well as moving clips. So the ABIM will test echocardiography image interpretation with moving video clips, both in the imaging studies component of the cardiovascular disease initial certification exam, which takes place on day 2, as well as throughout each section of the exam. And that pertains to the booklets that are covered in the initial certification as well as the maintenance of certification exam. Now, the echo portion of the ABIM imaging studies section consists of a half day on day 2. It comprises 48% EKG questions, 37% echocardiography questions, and 15% coronary angiography questions. And this information is taken directly from the ABIM cardiology board exam website. So the echocardiographic portion of the imaging studies section of the exam is designed to test your ability to interpret echocardiograms. They will give you a patient description as well as figures and video clips, as well as a comprehensive list of answer options with each echocardiogram case. And these answer options are grouped into the following sections: the left ventricle, the right ventricle, the atria, valvular heart disease, cardiomyopathy and systemic disease, pulmonary and aorta, pericardial and pleural diseases, and congenital heart disease. It's important to note that correct answers for some cases may include choices from several selections within a section. It may actually be appropriate to select more than one option within a section. However, a selection of answer options from all sections is not required for each case. The goal is not to identify every normal finding. nor is this an exercise in identifying minutiae or clinically unimportant details. And it really should be emphasized that all modalities of transthoracic and transesophageal echocardiograms may be presented, and all views will be appropriately labeled. So you may encounter 3D echo images on the exam. You may encounter M-mode images. You may encounter stress echoes. This slide here again summarizes the echo portion of the ABIM imaging studies section, which overall encompasses 37% of day 2 of the exam. And you can see the major emphasis is going to be on left ventricular size, function, and structure, as well as valvular heart disease. And cardiomyopathy comprises 4% of the exam. Pericardial and pleural diseases comprises 3% of the exam. And the remaining portions of the exam, including diseases of the atria, right ventricular size, function, and structure, systemic disease, pulmonary disease, diseases of the aorta, and congenital heart disease, will encompass less than 2% of the exam. I highly recommend that you study this ABIM comprehensive list of answer options in great detail. Knowing this answer sheet will help you expeditiously interpret the echocardiograms that will be put in front of you. So I am going to present you with several echocardiographic clinical vignettes that will be typical of the type of questions you may see on the ABIM exam. Not only on day 2 of the initial certification exam, but also sprinkled throughout the exam with respect to the maintenance of certification exam and day 1 of the initial certification exam. So the first patient is a 55-year-old woman who presents with pleuritic chest pain and shortness of breath. Her blood pressure is 85/50, and the following transthoracic echo is obtained. So on the left, we have our apical 4-chamber view, right atrium and right ventricle. On the right, we have our apical 3-chamber view. Here we have spectral Doppler across the mitral and the aortic valves, both during inspiration as well as expiration. This represents a subcostal 4-chamber view on the left, as well as an M-mode through the right ventricle from the subcostal view. This is a subcostal view of the inferior vena cava during inspiration. Which of the following is present on this transthoracic echo? A, pericardial effusion without tamponade. B, pericardial effusion with tamponade. C, pericardial constriction. D, pericardial hematoma. The correct answer is B, pericardial effusion with tamponade. Cardiac tamponade physiology occurs when the pressure in the pericardium exceeds the pressure in the cardiac chambers, resulting in impaired cardiac filling. The compressive effect of the pericardium is seen most clearly in the phase of the cardiac cycle when the pressure is lowest in that chamber. Hence, one of the earliest manifestations of tamponade is late diastolic, early systolic collapse of the right atrium, as was present in the apical four-chamber image in this patient with a massive circumferential pericardial effusion. Spectral Doppler in this patient demonstrated an inspiratory decrease in the transmitral E wave velocities of more than 25% by pulse Doppler, which is highly suggestive of cardiac tamponade. Normally, with inspiration, intrapericardial and intrathoracic pressures decrease to the same degree. In tamponade, intrapericardial pressures fall substantially less with inspiration than intrathoracic pressures, and as a consequence, there is a decrease in the E wave peak velocity. In the subcostal four-chamber view, there is diastolic collapse of the right ventricle, which is seen both on 2D imaging and M-mode imaging. This is a highly specific finding for cardiac tamponade. Finally, the subcostal view of the IVC demonstrates a dilated and plethoric IVC with less than 50% inspiratory collapse, indicating elevated right atrial pressures. These findings together are highly consistent with hemodynamically significant tamponade physiology by echocardiography. Now, you want to be able to differentiate pericardial tamponade from cardiac constriction. This example here comes from a patient who actually had heart failure symptoms. And you can see in this patient there is a small circumferential pericardial effusion seen in both the parasternal long and apical four-chamber view. Unlike the prior patient, though, if you look at the interventricular septum, you will see an inspiratory septal bounce. In constriction, the constrictive effect of the pericardium limits right ventricular filling during inspiration when intrathoracic pressures are lowest. And because of that, during inspiration, the blood moves towards the interventricular septum, creating the septal bounce. This is pulse Doppler through the mitral valve in a patient with cardiac constriction. Note there is mild inspiratory decrease in the E wave on the pulse Doppler in this patient. One of the key findings in cardiac constriction is annulus reversus of the E prime wave on tissue Doppler of the septum and lateral annulus of the mitral valve. So here, E prime of the septum measures 12.6 centimeters per second, whereas E prime of the lateral annulus measures less at 11.5 centimeters per second. Normally, E prime of the lateral annulus is going to be higher than E prime of the septal mitral annulus. This is a highly specific finding for cardiac constriction. In both tamponade and constriction, you will see a dilated and plethoric inferior vena cava with little inspiratory collapse indicative of high right atrial pressures. However, in constriction, unlike pericardial tamponade, you will get an expiratory increase in the A reversal velocity on pulse Doppler of the hepatic veins. And sometimes you may see an expiratory reversal. This particular patient demonstrates an expiratory increase in the A wave reversal. Again, this is a highly specific finding for constrictive physiology. This next patient is a 75-year-old male who presents from rehab with sudden shortness of breath and syncope 1 week following spinal fusion surgery. His blood pressure is 80/60, heart rate is 110 beats per minute. A CT-PE scan performed in the emergency room demonstrates large bilateral pulmonary emboli. The following transthoracic echo is obtained. So on the left, we have an apical four-chamber view of the right atrium and the right ventricle. And on the right, we have parasternal short axis view of the main pulmonary artery and bifurcation, including the right pulmonary artery. In addition to anticoagulation with heparin, which of the following would you recommend? A, IV thrombolysis with TPA. B, surgical embolectomy with extraction of floating emboli. C, catheter-based thrombolysis. Or D, ultrasound-enhanced thrombolysis, ECOS. The correct answer to this question is B, surgical embolectomy with extraction of floating emboli. This patient has a massive pulmonary embolism with thrombus in transit and acute right ventricular strain. He has hemodynamic instability and contraindications to thrombolysis given his recent spinal fusion surgery. This is a surgical emergency due to the high risk of mortality, and surgical embolectomy with extraction of floating emboli in the right heart should be performed. In some patients, mechanical support of the right ventricle with ventricular atrial ECMO may be appropriate. The apical four-chamber view demonstrating massive thrombus in transit within the right atrium and right ventricle is shown in the arrows. The appearance of thrombus in transit is diagnostic, though not highly sensitive in patients with pulmonary embolism. The main pulmonary artery and bifurcation view shows thrombus within the right pulmonary artery. Now, direct visualization of pulmonary emboli usually only occurs when the thrombus is large and centrally located. For this reason, echocardiography is not appropriate for diagnosing acute pulmonary embolism. However, it is appropriate for guiding therapy in patients with known acute pulmonary embolism. So this slide comes from the ASE appropriateness criteria. And so when is echo appropriate in pulmonary embolism? Again, echo is not recommended as a routine imaging test for the diagnosis of pulmonary embolism, as many patients with pulmonary embolism will have a completely normal echo. However, if you look at known acute pulmonary embolism to guide therapy, i.e. thrombectomy and thrombolytics, echocardiography gets an appropriate score of 8. It also gets an appropriate score of 7 for reevaluation of known pulmonary embolism after thrombolysis or thrombectomy for assessment of change in right ventricular function and/or pulmonary artery pressure. This next case is a 44-year-old male with hypertension and chronic renal insufficiency. His creatinine is 2.8. and he presents with sudden onset chest pain radiating to both shoulders and upper back. The following TEE is obtained. So here we have a mid-esophageal view on TEE at 115 degrees of the aortic root and proximal ascending aorta. This next slide demonstrates transesophageal echo basal esophageal view of the ascending aorta and origin of the left coronary artery. This next view demonstrates mid-esophageal TEE view with color Doppler of the aortic valve. Here we have transesophageal transverse view of the descending thoracic aorta. Which of the following is present on this TEE? A, type A aortic dissection. B, type 2 aortic dissection. C, type 3 aortic dissection, or D, linear artifact? The correct answer is A, type 1 aortic dissection. According to the DeBakey classification, a type 1 dissection starts in the ascending aorta and extends to the arch and often beyond. A type 2 dissection involves the ascending aorta only, while a type 3 dissection involves the descending thoracic aorta only. Linear artifacts can sometimes mimic aortic dissection flaps. However, they are usually not mobile and are not associated with entry and exit tears. Which of the following is the most appropriate therapy for this patient? The correct answer is B, surgical repair of the dissection with resuspension of the aortic valve only. This patient has a type 1 aortic dissection with severe aortic insufficiency, both of which are surgical emergencies. The dissection flap extends to the aortic valve and interferes with the coaptation of the aortic leaflets, leading to acute regurgitation. There is no involvement of the dissection flap with either the right or left coronary arteries. The flap begins just distal to the right coronary artery. Percutaneous endovascular stent grafts have predominantly been used for patients with aortic arch and descending thoracic aortic aneurysms and are increasingly being used in patients with complicated type 3 aortic dissection, as well as descending thoracic intramural hematomas and descending penetrating ulcers. They are not indicated in patients with type 1 aortic dissection and patients who are otherwise surgical candidates. The next patient is an 88-year-old female who presents to the hospital with chest pain over 24 hours associated with nausea and vomiting and an elevated troponin T of 0.5. Her initial EKG demonstrates no ischemic changes. She undergoes coronary angiography, which demonstrates an occluded left circumflex, and has a drug-eluting stent with restoration of flow and improvement in her symptoms. 3 days later, she develops pleuritic chest pain and nausea. Her blood pressures are noted to drop to 88/60, and her beta blocker is held. A transthoracic echo is obtained. So on this slide, you can see the occluded left circumflex that the patient presented with, and this was successfully revascularized with a drug-eluting stent. This slide here demonstrates her transthoracic apical long and parasternal long short axis views of the left ventricle and pericardial space. Which of the following is present on this transthoracic echo? A, ventricular septal rupture, B, ruptured papillary muscle, C, ventricular free wall rupture, D, ventricular pseudoaneurysm. The correct answer is C, left ventricular free wall rupture. Left ventricular free wall rupture is a cause of in-hospital mortality among patients with acute myocardial infarction. Since free wall rupture does not always present as a catastrophic event that results in immediate death, if recognized early and diagnosed accurately, emergency surgery may allow for successful treatment. So the clue with this patient was the presence of hematoma in the pericardial space, and you can actually see the free wall rupture in the apical long and parasternal short axis views. Now contrast a free wall rupture with a transthoracic echo of a patient with post-MI VSD, as is seen in the subcostal view, both with and without color Doppler. This particular patient became acutely hypotensive and developed a new systolic murmur. The ventricular septal defect is located at the mid-interventricular septum and appears as an abrupt interruption in the septal musculature. Like free wall rupture, ventricular septal rupture is associated with a grave prognosis, although survival is improved with early diagnosis and either prompt surgical repair or percutaneous closure. So here you can see color Doppler across the post-MI VSD with predominant left to right shunting across the defect. This image here is a mid-esophageal 4-chamber view with color Doppler of the same patient with a post-MI VSD, demonstrating turbulent flow in the right ventricle. So TEE may be necessary when the clinical suspicion of a complication of myocardial infarction is suspected and transthoracic images are not diagnostic. Another potential catastrophic complication of myocardial infarction includes a ruptured papillary muscle, as is illustrated in this apical 3-chamber view of the left ventricle with and without color. Now, this is actually represented by a highly mobile structure within the left ventricular cavity, as you see here. This particular patient became acutely hypotensive. Papillary muscle rupture, like ventricular septal rupture and free wall rupture, has a high likelihood of death. Again, prompt diagnosis and early surgical intervention may improve prognosis. The American Board of Internal Medicine wants you to be able to promptly recognize these potentially high mortality diagnoses that are diagnosed with echocardiography. So please be comfortable in making this diagnosis. Another potential catastrophic complication of myocardial infarction includes left ventricular pseudoaneurysm. Here we have an apical 2-chamber view demonstrating an inferior apical pseudoaneurysm. And on the right, we have a parasternal short axis view demonstrating an anterolateral left ventricular pseudoaneurysm. Now, pseudoaneurysms result from myocardial rupture, with the extravasated blood being contained by adherent parietal pericardium. Pseudoaneurysms are pathologically described as having a narrow neck, less than 40% of the diameter of the aneurysm, that connects the left ventricle to a large aneurysmal sac, which is lined by fibrous pericardial tissue. Pseudoaneurysms are associated with high mortality unless recognized early and promptly treated surgically. Now I want to switch gears a little and talk to you just a little bit about the types of echo Doppler equations that you may encounter on the ABIM initial certification as well as maintenance of certification exam. So both the initial certification and recertification exam will not heavily test ultrasound physics. However, a working knowledge of both the Bernoulli equation as well as the continuity equation is definitely going to be tested. So this slide here just summarizes the Bernoulli equation for fluid flow past an obstruction, which is a relationship between the pressures before and after the obstruction, V1 and V2, and quantities that depend on the type of fluid and type of obstruction. The unwieldy formula is actually simplified for clinical use by making assumptions regarding flow acceleration and friction. So the formulas that you need to be familiar with for the ABIN exam are these two. The change in pressure is equal to 4 times V2 squared minus V1 squared. And if V1 squared is very small, you can further simplify this equation to the change in pressure gradient is equal to 4 times V squared, where V is the velocity of blood flow in meters per second. So this other equation, which represents a workhorse equation that is utilized every day in busy echo labs, is the continuity equation. Now the continuity equation is summarized in this slide, and it is based on the principle of the conservation of mass, which can be applied to any specified region of flow, providing there is no loss of fluid from the system. So whatever mass flows in must also flow out. The most common clinical area where the continuity equation is applied is the calculation of aortic valve area in a patient with aortic stenosis. Here, by the flow velocity integral of the left ventricular outflow tract is measured with pulse Doppler, as is the annulus of the aortic valve, and also the flow velocity integral across the stenotic aortic valve is measured by continuous wave Doppler. And so the cross-sectional area of the LV outflow tract times the flow velocity integral times of the LV outflow tract is equal to the cross-sectional area of the aortic valve times the flow velocity integral of the aortic valve measured by continuous wave Doppler. This equation is further simplified, and you must have a working knowledge of this equation. So a simplified continuity equation will give you the aortic valve area in centimeters squared, which is equal to 0.785 times the LVOT diameter squared times the LVOT VTI by pulsed wave Doppler divided by the aortic valve VTI measured by continuous wave Doppler. So make sure you know this equation and make sure you know how to calculate a patient's aortic valve area if given this data. This next patient is a 65-year-old woman with hypertension, diabetes, and hyperlipidemia who is referred for an exercise stress echo to evaluate for dyspnea on exertion. She exercises 5 minutes on a Bruce protocol, achieving 82% of her maximum predicted heart rate, and stops because of shortness of breath. Her blood pressure and heart rate response to exercise are appropriate. EKG demonstrates normal sinus rhythm with LVH, and 1 millimeter horizontal ST segment depressions are noted in leads 2, 3, AVF, as well as V1 to V6. So here we have stress echo images of the apical views, both at rest on top and with stress on the bottom. So on top we have an apical 4 at rest and an apical 4 chamber view post-exercise. We have an apical 3 chamber view at rest and an apical 3 chamber view post-exercise. This next slide is from the same patient and illustrates the parasternal windows. At rest, we have a parasternal long axis view on top, and on the bottom we have the same patient parasternal long axis view immediately post-exercise. In the upper right corner, we have a parasternal short axis view at rest. And on the bottom, we have the parasternal short axis view immediately post-exercise. Which of the following is present on this stress echo? A, negative for ischemia. B, non-diagnostic for ischemia due to failure to exceed 85% of her maximum predicted heart rate. C, positive for ischemia in the LAD territory. D, positive for ischemia in the right coronary artery territory. E, positive for ischemia in the left circumflex territory. The correct answer is C, positive for ischemia in the LAD territory. Wall motion abnormalities in this patient involve the entire anterior septum, anterior wall, and left ventricular apex, and are consistent with ischemia in the left anterior descending territory. This patient underwent coronary angiography and was noted to have a 90% proximal LAD lesion that was successfully treated with a drug-eluting stent. This next patient is a 45-year-old male with evidence of right heart failure on exam, who was referred for a TEE to further evaluate the mechanism of severe tricuspid insufficiency and severe pulmonic insufficiency, which was detected on his transthoracic study. So these are 3D TEE images of the tricuspid valve on the left and the pulmonic valves on the right. And so you have en face images of both the tricuspid valve and pulmonic valve. What is the mechanism of this patient's valvular heart disease? A, rheumatic. B, functional. C, lupus. D, carcinoid. Or E, myxomatous. And the correct answer is D, carcinoid. Carcinoid valve disease is a rare cause of valve disease, predominantly affecting the tricuspid and pulmonic valves in patients with neuroendocrine tumors that result in fibrous deposits on the endocardium and valves, causing thickening, retraction, and immobility of the valve leaflets. The characteristics are readily appreciated on 3D TEE. This patient successfully underwent mechanical valve replacement of both his tricuspid and pulmonic valves. This next patient is a 61-year-old Chilean male who presented with progressive weight loss, anorexia, shortness of breath, and peripheral edema. His labs are notable for a creatinine of 1.7, a hematocrit of 36 with a white blood count of 10, with 60% neutrophils, 20% monocytes, and 20% eosinophils. The following transthoracic images are obtained. So on the left, we have an apical 4-chamber view, and on the right, we have an apical 2-chamber view. Which of the following is present on this transthoracic echo? A, cardiac amyloidosis. B, Fabry's cardiomyopathy. C, Leffler's cardiomyopathy. D, apical hypertrophic cardiomyopathy. The correct answer is C, Leffler's cardiomyopathy. Leffler's myocarditis is caused by eosinophilia, causing endomyocardial damage and a restrictive cardiomyopathy, leading to dense fibrosis, particularly at the LV apex, as is seen in this patient. It is common in patients from South America and Africa, as well as Asia, and is associated with high morbidity and mortality. This next patient is a 56-year-old woman who presents with dyspnea, which is worse with standing straight. The following transthoracic echo is obtained. So on the left, we have an apical 4-chamber view, and on the right, we have an apical 2-chamber view. Which of the following is the most likely diagnosis? A, left atrial thrombus, B, left atrial myxoma, C, lung carcinoma with Mets to the left atrium, D, melanoma with Mets to the left atrium. The correct answer is B, left atrial myxoma. Cardiac myxomas are the most common tumors of the heart and echocardiographically are characterized by a gelatinous appearance and most commonly are attached to the interatrial septum by a thin stalk, though they can occur anywhere in the heart. They can cause functional mitral stenosis and are associated with an increased risk of embolic stroke due to clots forming on the tumors and then embolizing. Surgical excision is the treatment of choice, followed by anticoagulation in patients who are not surgical candidates. This next patient is a 58-year-old male who presents with shortness of breath and is 6 years status post mitral valve repair. A transthoracic echo shows severe mitral insufficiency, and TEE is obtained to further evaluate the mechanism of mitral insufficiency. So this slide demonstrates a 2D TEE with and without color Doppler of the mitral valve from the mid-esophageal 4-chamber view. This slide demonstrates 3D TEE of the repaired mitral valve with and without color Doppler in the same patient. So this is the surgeon's view of the mitral valve obtained with 3D TEE with and without color Doppler. What is the mechanism of mitral insufficiency? A, anterior paravalvular leak, B, flail P2 scallop, C, flail P1 scallop, D, flail A1 scallop, or E, flail A3 scallop. The correct answer is E, flail A3 scallop. 3D TEE demonstrates a flail A3 scallop. 3D TEE is especially useful in localizing mitral valve pathology as it allows all 6 scallops of the mitral valve to be visualized simultaneously. The boards will test knowledge of the anatomy of the mitral valve on 3D TEE. This next patient is a 54-year-old male who is noted to have a dilated ascending aorta measuring 4.8 centimeters on transthoracic echocardiography of unclear etiology. He has no known history of hypertension or connective tissue disease. There is no family history of aortic dissection. His aortic valve morphology was not well visualized on TTE. However, there was no significant stenosis or regurgitation, and thus TEE was performed. So this slide demonstrates the transthoracic echo, which demonstrated on the right parasternal view an ascending aorta, which measured 4.8 centimeters. And to the right, you have a basal esophageal view of the aortic valve, seen on 3D TEE, with the 2D MPR images seen below. On the basis of the 3D images of the aortic valve, what would you recommend? A, continued surveillance of the ascending aorta and surgical repair once the ascending aorta reaches 6 centimeters. B, elective repair of the ascending aorta now. C, continued surveillance of the ascending aorta and surgical repair once the ascending aorta reaches 5.5 centimeters. The correct answer is C, continued surveillance of the ascending aorta and surgical repair once the ascending aorta reaches 5.5 centimeters. This patient has a bicuspid aortic valve and bicuspid aortopathy. Most major society guidelines recommend prophylactic surgery on the aortic root or ascending aorta at a threshold of 5 to 5.5 centimeters, also taking into account the patient's body surface area. If the patient has a family history of aortic dissection or is being cared for at a center with surgical expertise in aortic diseases, earlier intervention with an aortic root or ascending aorta at 5 centimeters may be warranted, or if there is greater than a 0.5 centimeter increase in aortic diameter over 1 year. This next patient is a 55-year-old woman who presents with a TIA, and the following TEE is obtained to evaluate for cardiac source of embolism. So this demonstrates both two-dimensional and three-dimensional basal esophageal view of the aortic valve. Which of the following is present on this TEE? A, aortic valve thrombus, B, aortic valve vegetation, C, aortic valve myxoma, or D, aortic valve papillary fibroelastoma. The correct answer is D, aortic valve papillary fibroelastoma. Papillary fibroelastomas are the most common tumor located on the heart valves and characteristically are small tumors that do not cause valvular dysfunction and consist of multiple frond-like projections, usually on a stalk. When they are associated with a TIA or stroke, or when they are larger than 1 centimeter, treatment usually consists of surgical resection. Patients who are not surgical candidates are usually anticoagulated. This next patient is a 46-year-old woman with end-stage renal disease who is 13 months status post mitral valve replacement. She presents with shortness of breath and respiratory arrest requiring intubation. A TEE is performed to evaluate her prosthetic mitral valve. And this represents 3D TEE images of the mitral valve. On the left, we have the mitral valve from the left atrium, and on the right, we have 3D images of the mitral valve from the left ventricle. Which of the following is present on this TEE? A, normally functioning bioprosthetic mitral valve. B, normally functioning mechanical mitral valve. C, severe prosthetic mitral valve stenosis. D, partial dehiscence of the bioprosthetic mitral valve. The correct answer is C, severe prosthetic mitral valve stenosis. This TEE demonstrates a bioprosthetic valve to be in stable position with severe restriction of opening of the mitral valve leaflets seen from both the left atrial perspective and left ventricular perspective. This patient had early bioprosthetic aortic valve failure exacerbated by renal insufficiency. She underwent successful valve-in-valve percutaneous replacement of her mitral valve as she was too ill for re-op surgery. She will likely require re-op mechanical mitral valve replacement in the near future. This next patient is a 55-year-old woman who presents with fever, chills, and dyspnea. Her EKG demonstrates new first-degree AV block, and the following transesophageal echo is obtained. So this is the basal esophageal view of the aortic valve on the left, as well as the aortic root on the right. Which of the following is present on this TEE? A, aortic valve abscess. B, aortic valve vegetation. C, aortic root aneurysm. Or D, both aortic root abscess and aortic valve vegetation. The correct answer is aortic abscess. An aortic root abscess is diagnosed when the aortic wall is abnormally thickened, and there may be areas of lucency as well. Normal thickness of the aortic root is 3 millimeters or less. In this patient with fever, chills, and positive blood cultures, as well as first-degree heart block, the anterior aortic root is abnormally thickened. The patient was brought to the OR for surgical debridement and repair of his aorta. So again, I'm just going to show you the abscess, which is seen right here on the basal esophageal view at the level of the aortic valve. There's no evidence of vegetation on the aortic valve leaflets. And this is the anterior aortic root, which is abnormally thickened. This should normally be pencil thin, as you see above here. This is the posterior aortic root, which is normal. This is the location of the anterior aortic root abscess. So in summary, I've presented you with a lot of clinical vignettes that are typical of the types of images and questions that you will see on your ABIM initial certification as well as maintenance of certification exam. The ABIM exam, both initial certification and recertification, tests echocardiography image interpretation with moving video clips as well as still images of all echo modalities throughout the exam. The ABIM initial certification exam has a separate half-day EKG and imaging section, which will take place on day 2 of the exam. Echo interpretation is approximately 37% of the content of day 2 of the exam. Familiarity with the ABIM coding system for echocardiograms is key for success. Although the ABIM MOC exam does not have a separate imaging section for testing echocardiography, it is essential for all taking the recertification exam to be familiar with all the pathologies that are listed on the ABIM echocardiography coding form, as these findings and abnormalities will make their way into the main exam in the form of a multiple choice question. ABIM multiple choice questions will focus on appropriate diagnosis and treatment, as well as indications for surgery. Transthoracic echo, TEE, stress echo, and 3D echo images will be included on the exam, with far less emphasis on M-mode findings than was previously noted on past exams.